Elkin, dear Elkin, thank you for your kind invitation. It's always a pleasure to meet you. I would like today share with you what we have learned about from 40 years of practicing adult traumatic brachial plexus surgery. Most of these European surgeons who developed this surgery in 17th and 18th. A special mention for René Gilbert and Piero Raimondi, who carried out an immense work on the obstetrical brachial plexus palsy. We have learned a lot about the anatomical organization of the brachial plexus with its many variations. Luciano Poitvin in Buenos Aires, by his important dissection work, made us understand the compression mechanism of the plexus in the interscalenus and costoclavicular spaces, which led us to propose a surgical protocol to treat the neurogenic thoracic outlet syndrome without resecting the first rib nor remove the anterior scalenus. It is important to resect the ligament and muscle structures in the interscalenus space, and in particular the costoseptocostal ligament, which fixes the thoracic 1 root. The partial resection of the middle scalenus reduces the pulley effects, which puts under tension the lower trunk. On the other hand, it is never in direct contact with the scalenus anterior. The exploration of the costoclavicular space allows to resect the Caldani ligament and the fascia of the subclavian muscle. François Bonnel perfectly observed the important variation of the fascicular distribution and confirmed that the C7 roots diffuse through the plexus. The use of the microscope is essential to assess lesions in apparent continuity and also to remove the connective tissue, which make up 77% of an axillary nerve. The surgical strategy has been perfectly developed by Algina Rakas. I encourage you to discover his operating diagrams in the book by Chantal Bonnard and Albert Slouf. There is a triple avulsion of C5, C6, C7, which is treated by a double neurotization using the accessory nerve and 2 intercostal nerves. Before rushing into a neurotization, take the time to explore the entire plexus. You will sometimes have a good surprises. We have also shown the importance of performing surgery in the first months of the accident, which help us to reduce the pain syndrome. It is advisable to be systematic thanks to a powerful imaging and to identify the meningocells, which provide information on a partial or total avulsion of the roots. The notion of neurotization is old, and Algina Rakas reminds us in this history. As early 1913, Tuttle described neurotization by the accessory nerve. But the challenge is terrible because the brachial plexus is 130,000 fibers, while an accessory nerve is 1,700 fibers, and an intercostal nerve 1,300 with a majority of sensitive fibers. In Europe, since 1917, we have used the accessory nerve a lot to neurotize the biceps and then the suprascapularis with useful functional result ranging between 50 to 60%. Personally, I have used the intercostal nerve to resensitize the ulnar area and avoid burns and trophic disorders. But it's taken more than 2 years of regeneration to achieve a useful result. The best concept of neurotization that gives spectacular result is the ideas of Christophe Oberlin, who neurotized the biceps using 10 to 15% of the fibers of the ulnar nerve. This concept is quickly developed to neurotize the deltoid by a branch of the radial nerve. Other neurotization with less spectacular results have been developed in the forearm. Our Chinese colleagues in total avulsion have greatly developed neurotization using the contralateral C7 route with sometimes spectacular result, in particularly for treating the obstetrical brachial plexus palsy. We mistakenly believe that using vascularized nerve grafts will transform our functional outcomes. One of the difficulties in applying this technique is the scarcity of the donor site. In the case of CA-TH1 avulsion, Birch used the antebrachial part of the ulnar nerve. Personally, to avoid sacrificing the ulnar artery, we prefer its brachial part, well described by Elisabeth Le Breton in Nice. For the plexus, with a 2-year follow-up, we didn't notice any difference between fascicular graft and vascular graft. Now we reserve them when the tissue bed is unfavorable, and particularly for Volkmann syndrome or after radiotherapy. End-to-size sutures remain a speculation which do not provide a useful functional result. Nerve allografts are topical and will be very useful in repairing the plexus. Attempts to pre-treat grafts according to the Susan McKinnon protocol have not been clinically proved. In contrast, decellularized allografts are promising, but it should be remembered that while the basal membrane problem is resolved by this allograft, the recipient's Schwann cell problem, which is essential for the progression of neuritis in the allograft, is not yet mastered. A multi-center North American study which treat substance loss to 5 to 50 millimeter would show that these allografts give result equivalent to autograft and superior to neurotube. The future should provide us with solution insofar as certain molecules prevent apoptosis of the nerve cells. Gene therapy should also help the patient to activate the development of Schwann cells, stimulate nerve growth, and preserve muscle from atrophy. The principle is to use a fragment of viral RNA to impact the different sites of nerve regeneration. But I think we have to wait and see. On a practical level, we would like the glue to improve, which would secure our graft. We are surprised by the paucity of research on this subject. While thinking of our operating comfort, we will soon have the possibility to separating ourselves from our operating microscope by using a very high definition camera and screen without 3D diffusion. I hope that it will be the future for us, because a long view through the microscope is really uncomfortable. There is still a long way to go, but we remain optimistic because the next generation of surgeons will be very active to find a new concept in the difficult problem to treat the brachial plexus surgery. Thank you very much for your attention. Thank you, President.
Gracias, doctor Merle. Definitivamente escuchar la historia de manos de los que la han...
To listen this history by some people that have been part of this is a privilege. Thank you for your presentation,